Hi, guys. We're in week 5, and we're going to talk about the COVID-19 pandemic this week, a global disruption. We are 1 week over the half, which means we're almost there, and that's great. And you guys are doing really well. Keep it up. Come speak to me if you want to have a chat during office hours. I am here for you. So let's get to it. COVID-19 was a major event in recent history. It was a pandemic. You have pandemics that affects the world globally, the virus, and then you have epidemics like in small places, right? This went from an epidemic to a pandemic, and it affected the entire world. We are going to talk about how the virus spread, what public health strategies were used, and most importantly, how different communities experienced the pandemic in different ways. And we got to see, for example, some states were affected more than others, some neighborhoods, some professions. It really started out as an old people illness, right? But it ballooned very quickly as an everybody problem. The timeline, December 2019, the first cases were reported. March 2020, that's when we declared it a global pandemic. We had a shutdown. I remember I was on one of the last planes let back into the country. 2020 to 2021, lockdowns, closures, economic strain. 2022 and beyond, ongoing recovery, adaptation, and a shift towards managing long-term consequences. So we didn't really know in the beginning how COVID-19 transmission happened, but then we slowly found out that it's spread mainly through respiratory droplets, and that is like from talking, from coughing, from breathing, and that's why the health strategies included masks, social distancing, contact tracing, and staying home when sick. And wearing masks became, a really controversial thing, but really in Asia, even before the pandemic, when you're sick, people wear masks. That's a thing that they do. But these strategies that we took on weren't just about medicine. They were about protecting communities by changing daily behavior. And the problem was that it was an unequal impact because not everyone was affected the same. So here's something that we have to acknowledge. Some communities were hit harder as compared to others, some professions as well. So people working in grocery stores, warehouses, healthcare, and cleaning service, the show had to keep going on for them. I remember you could still order Amazon. You could still order your groceries. People still had to eat. They couldn't stay home. They were our essential workers. Many of these people lived in crowded housing or had little access to testing or care. And then you also had your frontline workers like your first responders, your doctors, your nurses, your firefighters. I remember a story where, 2 first responders were married. They both got COVID. They died. They left their young daughter as an orphan. So the places where you live, work, and go to school shaped your exposure and your recovery. So one thing, a lot of people think, well, COVID wasn't that bad. It was the flu. It didn't really affect me. I don't think I got it. It's over. For me, can we move on? But here's the thing. Long COVID is still with us. And for some of us, the pandemic isn't really over. And I want to share personally that I'm still living with long COVID. I'm one of those people who got sick and never fully recovered. 5 years later, it's not something you just get over. Not if you almost died like what I did. And you'll see my TED Talk about it this week. You'll see my documentary that I made about it. I actually almost died, so it's a miracle that I'm here. And long COVID symptoms can involve fatigue, brain fog, pain, and other ongoing symptoms. And sometimes in people who were previously healthy, like myself. I never had a health problem. There was never anything wrong with me. I hardly ever had to go to the doctor except for my annual checkups. So many people with long COVID face misunderstanding from others. People don't understand why I don't look sick, right? What sickness looks like. They don't understand invisible illness. There's difficult working, parenting. There's gaps in my care. So when we study COVID, we also need to understand the long tail of the pandemic and how it continues to shape people's lives, especially in under-resourced areas. So for me, for example, I live rural. I live here in Southeast Texas. It's rural. There's not a long COVID specialist here in this town. No one in Beaumont specializes in long COVID. So any kind of help that I need, I have to travel all the way to Houston for that, which is an undue burden. And I'm lucky in that I can do that. Not everyone can afford to. So during the pandemic, life moved online, school, work, doctor's visits, but not everyone had reliable internet. Not everyone had a private space to learn or to rest, and not everyone had a device for every family member. So a lot of these things you and I might take for granted, but for some people, it was really hard to go online. And this is called the digital divide. And the digital divide meant that some students fell behind, some families couldn't access care or information, and that's why access to technology is now part of public health. It's a very important part, and I am really glad about telehealth, for example, because now I can see my doctor online for, a lot of issues, which means that I can access my doctors in Houston with right from the safety of my home. So I want you to reflect on what COVID-19 looked like in your own life or neighborhood, how it changed your routines, access, or maybe perhaps even your health. A lot of people have long COVID and don't even know it. A lot of people got more health problems. Maybe they got an increase in diabetes or cardiovascular disease, and they don't even know it. So epidemiology tells us what happened, and sociology helps us understand who was most affected and why. And social epidemiology merges the two. And that's what you'll explore. I'd like you to do it with empathy and critical thinking and with your own lived experience as a guide. And I just want to talk for a moment about the realities of living with long COVID and what an invisible illness is. I want to just give a few minutes to that because in my healthcare class where I talk about healthcare and society, what a lot of people don't realize, especially healthy people, is that a lot of us, most of us, are ableist, and not because we mean to be, but it's just because when we think of an illness, we think that person, if they are ill, then their disabilities should be visible. But all illnesses aren't necessarily visible. And that's why a lot of people with long COVID had a really hard time, because we caught the virus and then, they say the virus is supposed to clear up in 2 weeks, but it didn't. We kept getting sicker and sicker and sicker. And then we never fully recovered, even though once we were out of the acute phase, so then, I'm not sneezing or coughing anymore. I mean, I had a cough. I had a cough for 3 years long, 3 years straight. I had a cough. To this day, I still have a sore throat. I get terrible headaches, migraines, extreme fatigue, and if I exercise, I have post-exertional malaise. It hurts after I exercise. So the thing is that sits with you, and it doesn't go away. That experience doesn't go away. It's something that will stay with me for the rest of my life. And I'm not alone. There's a lot of people out there like me. And I happen to be at least functioning to where, I can at least get out of my bed. In the beginning, I couldn't even do that. So I want you to take away from this that not all illnesses are visible. And some people can look perfectly healthy, beautiful, and well put together, but be extremely ill and have a disability. And I need you to keep that in mind. And it's important that accommodations are given to people like myself who it's understood that if I was in a wheelchair, that you would have to provide me with a ramp to get into a building. It's understood. Or to get onto a stage, I would need a ramp to be able to do that effectively. When you can't see my illness, the accommodation of what I need in order to function, as close to normal as what I can, is not always as self-explanatory as a ramp. So just keep that in mind, that not all illnesses aren't visible. Some illnesses are invisible, and that doesn't make a person any less sick than someone, for example, in a wheelchair, or someone with a disability, a hearing disability, and who's deaf, or someone, sometimes, someone with a dyslexia, for example, might need more time on a test. Someone with long COVID who has brain fog might also need more time. Or they can't stand all day. They might not be able to walk that day. So it's important to keep in mind that all illnesses are not visible, that you will be tested on that for sure. And just think of some of the illnesses, some of the disabilities that you can't see. For example, mental health. You can't see depression. You can't see chronic depression. You can't see bipolar. You can't see anxiety. Sometimes you can see like the effects of it, what makes people do, but you don't necessarily see it when somebody has it or not. So just keep that in mind, because as we move through society, people who are healthy and able-bodied tend to think only in that framework of an able-bodied framework. I did that too, until I got sick, until I got a disability. So now I think in terms of, okay, if I want to, for example, film this recording, this lecture, what kind of things do I need to prepare for myself in order to film this lecture well? Somebody who's able-bodied doesn't have to make those decisions. And when you look at me, you don't necessarily think that I have to plan all this out in order to give this class to you in this way. So just keep that in mind. Main takeaway is not all illnesses are visible. Invisible disabilities do exist. I wish you guys a good rest of your day. I hope that you are learning something in this course, and I would love to sit down and talk with some of you guys in office hours. I am here for you. If you have questions, just holler. Bye.